So let me introduce my country, Tanzania.
Yeah, no.
Tanzania is located in East Africa, just below the equator, and it's tropical weather. It's famous for its wildlife reserves. We have a lot of national parks here. One of them is the Serengeti National Parks, the famous one. And we have the Mount Kilimanjaro and the Zanzibar, which is famous for its beautiful beaches. So we are located in the East Africa. The population here, we have around 50 million people in Tanzania, and most of these are living in the villages where they are exposed to the Savannah Wildlife National Parks, and they are the risk group because they are living with those wild animals. So most of the patients uh, in Muhimbili are coming from the up countries. They are referred to the national hospital. This is the number one, it's the national hospital here. So we get a lot of cases from up countries, from the ranging from tumors, ranging from traumas, ranging from the animal bites. So we had a chance to see this kid who sustained a hyena bite in the villages close to the Selous National Park. Uh, let's recap on the WHO animal bites key facts. If we recap, so you find that most of the animal bites cause a significant cause of morbidity and mortality worldwide. And up to 5 million people are bitten by snakes every year. And the majority are in Africa and Southeast Asia. I hope Nepal, I'm not sure about Nepal, but I think it's one of the countries which is also included in the Southeast Asia. So looking on the animals which normally cause animal bites, we have snakes, we have dogs, and the rabies is a significant health concern following dog bites or cat bites or monkey, and even hyena. And I was looking on the literature, but I could not find the literature concerning the hyena human bites from the WHO. So I think there are very rare cases that have been reported, and probably this is one of them, and it's a peculiar case. For me, this is my first case of an animal human bite. We can also see the animal fact itself. The hyena is a dog family animal, and you can see the picture there. I think most of you know the animal. Movement.
Yeah.
Yes, we can see it.
Their walking speed is 1 to 2 miles per hour. Most of the time they are trotting. Trotting is 5 miles per hour. Sometimes they run, and the speed reaches up to 37 miles per hour. The females can weigh up to 70 kilograms, but males weigh less than that. Now, if you look on the bites, among the top 10, hyena ranks number 8 in the animals with the strongest bite. The average strength of a human bite force is normally 162 pounds. So hyena has 60 times that of the human bite. Hyena has a bite force of 1,100 psi. So we can find now the bite force is severe enough to cause crushing injuries on our bodies. I mean, it can tear the muscles, it can tear the tendons, it can tear the bone itself, and it's very dangerous if you have such injuries. Normally, we have pathogens also living in our oral cavities, and as for the animals as well, they have pathogens living in the oral cavities. So this chart shows the specific animals with the names of the pathogens which habitates in the mouth. For example, we have mammals, we have rabies. Dogs have Capnocryptophaga canimosus, and the rest you can see there. Hyena is not included in this list, probably because it's very rare, or there have been no research on the pathogens in the oral cavities of hyenas. But the common vertebrae, we have Clostridium tetani, which causes tetanus in most of the vertebrates. We have this one also, the common bacteria found in the dogs. You can see aerobes and anaerobes. We have the streptococci, the staph, Staphylococcus aureus, and other species, because there are so many species, including staph epididymis and others. So one has to know that when we get an animal bite, it's not only the crushing injury, but we expect the infections from these bacteria. So in history taking, when you're taking history, you should take into account circumstances of the injury. You should also take into consideration the type of animal which is involved, the current location of the animals, the ownership, the vaccination status. For example, dogs. Some dogs we are living with dogs in our cities, so we should make sure that we have the dog has a vaccination status. Also, should check on the patient's underlying medical condition, the other diseases, the comorbidities. If the patient has any other diseases, you should also put it into consideration, as it may exacerbate the condition or make it worse. Drug allergy, because we are treating infection, so you should make sure that you know that if this patient is allergic to sulfur, allergic to penicillin and the other stuff. You should also check on the tetanus immunization status, because these bacteria, Clostridium tetani, are found in the soil, and probably when you are bitten by an animal, you can have, when you are struggling to escape from the animal bite, you can have some soil getting to the wound. So these are the most common points to consider when you are taking the history. And on physical examination, you should check on the location, on the type, and the depth of the wound, because this explains how aggressive you are going to treat this patient. Location, as we are neurosurgeons, so we are looking on the skull. It's the most affected part, or we are looking on the spine. But you can also see if the thighs have been involved, so that you can treat as well, because patient tends to get multiple traumas. And the type of the wound, if it's the gloving wound, say the skin has been removed, exposing the bones and the other soft tissues, or the depth of the wound as well, like what we are going to see on this patient I'm going to present. You should also check on the range of motion and the neurovascular functioning. The patient, sometimes they get shocked because of bleeding. They may come to you sweating a lot, has lost a lot of blood. They may go into hypovolemic shock, so you should check on all of these. Check the blood pressure, check the heart rate, check the skin condition. You should also check on the signs of infection. It depends. Like we are in Tanzania, patients are coming from up countries. Sometimes they delay coming to our national hospital. Patients may come 2 days or 3 days later after the injury with the infection, which has gone very worse. Like we have also seen some of the, before we saw one patient who was kicked by a buffalo, and he arrived to us with the CSF, with the deep wound in the skull because of the horn of the buffalo. He presented to us like 3 to 4 days later from the day of injury. But this patient was from another town. You should also check on the lymph node, and if you have X-ray, you can X-ray the wound because it's close to the joint or to the bone. Right now we have the CT scan, so you can do CT scan as well. Again, we have the principles on animal bites. We have what we call the famous helicopter. Uh, the helicopter. This is an acronym. It's an acronym for the management of animal bite wounds. So you should take into consideration you should check the history, the presenting complaints. You should examine the patient. You should do a rebero cleansing of the wound and the irrigation. And C stands for the closure and the culture consideration. You can take blood culture or CSF culture. Uh, you should also check on the operative cleansing and the closure. The way you close, you should make sure you are not closing any infection in the wound. You should also check on the prophylactic or therapeutic antimicrobial agent used. You should also check on the tetanus immunization as we have spoken. You should elevate, and you should check on the rabies risk, because this is the potential risk as we have seen from the WHO data. This is the potential risk from the animal bite. Now we can go and see the case. Uh, I'm presenting to you a 3-year-old boy who was attacked by a hyena one day prior to the admission while asleep at night. According to the informant, who was not the biological mother, because the mother was living away from the kid, this kid was circumcised. You know, it's a culture, it's an African culture. People do circumcision, especially Muslims. And they were living close to their houses. I may say it's a poor house with a door which can be easily be broken by strong animals. So they went into sleep, and at night, the hyena invaded their house and managed to block the door. He went inside, and there were so many people living in that room, but he just selected one man. I mean, a boy. It's this boy who was having a fresh wound from the circumcision wound. So we were thinking probably this hyena was smelling the fresh wound. As we know, hyena they hunt sometimes by just smelling even 20 kilometers away. So he's captured the boy. He was pulling out of the door. And the boy started crying. And then the other elders, the uncles, woke up at night, and they found that the boy was taken by a hyena. They hold the legs so that on an attempt to prevent the boy from being taken. So it was like the hyena is pulling on one side, and the uncles are pulling on the legs while trying to kill or taking any weapon to kill the hyena. As a result, the hyena managed to bite. Is because of his bite force. He managed to degrove the scalp, the pericranium. He took the bone from the right temporal parietal, and even the dura was teared, exposing the brain. And this boy, when presented to us, the wound was smelling with the brain outside, which was already dead. That part of the brain which was herniated. So the boy had a dura defect. He had severe pain, and because he presented today to us one day later, the boy had a hemoglobin level of 4 gram per deciliter, which is very severe anemia. So, and the mother reported also the boy vomited twice while uh, while to the other hospital before he was brought to us. But the boy had no loss of consciousness. The boy had no any convulsion. This is the wound. You can see the boy. This is the you can see the location of the wound is on the right parietal temporal with the exposed bone, exposed dura, and exposed. Right now, you cannot see the brain because this was after the first operation, but the whole scalp was taken away. It's a disgroving wound. You can see the extent of the wound. You can see this boy. the branches of the superficial temporal artery probably were severed, and as well as the posterior auricular artery was also severed. So the blood supply to this wound was poor. But after receiving this boy, we immediately take this patient to theater, where we did surgical debridement. So when we say surgical debridement, we mean we are cutting the dead tissues, or the non-viable tissues, the devitalized tissues. We are cutting them, and then we are trying to wash the wound with a lot of normal saline and a lot of antimicrobial. So we used, in this case, we used iodine, which was diluted on the part which close to the bone, not on the brain. But we also managed to use the hydrogen peroxide, and with a lot of irrigation.
Of the presentation, posting it on social media, saying that he's talking about this now.
So we managed to close the wound. You can see close to the ear. You can see something which looks like it's dead, but it's actually not dead. There is a sagittale below the pericranium. We took the pericranium from the patient to cover the wound, that part of the brain which was exposed. So we took the dead brain out. We put the sagittale to control the hemostasis, and then we took the pericranium to cover the dead the open space, and then we took this patient to the ICU, while calling for plastic surgeons to come and review this baby. We also gave blood to this patient because of severe anemia, so the HB improved. And these were the findings at at our casualty. I forgot to tell you, he received the anti-rabies. As you know, the protocol needs to give the immediate immunoglobulins for control of rabies, and then later you can give vaccine. So we gave anti-rabies immunoglobulins, 260 units, and we came to give vaccine later, so that to make sure that because we are not sure of the animal status, because it's the wild animal. The boy also received the blood transfusion. He got analgesics and IV fluids and the preoperative IV antibiotics. On examination, before I think I changed the slides, but this was the wound was false meaning, and it was the CSF was leaking from the wound. So these were the CT scan findings. You can see the CT scan findings showing that the bone has been lost from this part, and probably the STA was also torn. That's why the baby had a lot of bleeding. In theater, this is what we did, as I explained, surgical debridement. We did duroplasty using the pericranium from the fresh site, and then we kept the patient on IV metronidazole, IV augmentin, and gentamicin. And we asked the plastic surgeons who came later to review this baby. But on review of this baby, the plastic surgeon, to be honest, they had no, their opinion was just to control the infection, to control the CSF leak, and later they are going to review on what they are going to do. But actually, when they just came there, they had no choice. They had no plans on what they are going to do on this patient. So we agreed on them that okay, we will take care of the baby until the wound is clean. So immediately post-operative, this baby was febrile. The hemoglobin level raised up to around 6 or 7 because of the we could not give much blood for a feeding of the fluid overload on the heart, and had no signs of CSF leak post-operatively. But 48 hours postoperatively, this patient had CSF leak, which was just observed. We say, okay, we can just observe this patient for the extra 24 hours by just putting some dressing. And if the leak was still going on, we took again the patient to theater to do surgical debridement. So we went again for the second time to do surgical debridement and uroplasty. But this time we just went to repair that part which was leaking. And we did it. We repaired that part. We saw it. It was on the pericranium side, not on the dura side. It was on the pericranium side because probably the pericranium was teared also. We repaired it, and then we did the Valsalva maneuver. Valsalva maneuver is the anesthesiologist is trying to hyperventilate the patient and to see if there is any CSF leak. So we confirmed that there was no CSF leak after the Valsalva maneuver. And again, we called the plastic surgeon who just changed the medication. He just ordered to change the medication. He ordered IV cefoso to replace the IV augmentin. He started on the cephalosporins. So we stopped IV augmentin and then we gave cefoso. Probably because of he thought this one, the cephalosporins are very good in gram-positive pathogens. So the plan was to change the antibiotics. But 1 week later, there was still CSF leak. There was a small defect again on the pericranium which we used. So you can see this is the wound. Unfortunately, you cannot see that part which was leaking, but it was there. So this time we decided not to use the pericranium again. We used the Duragen. And we managed to cover the whole defect, including the dura. So we look over the margins of the dura and the pericranium. We take the Duragen and put it to cover everything over there. And this baby, as you can see, the wound was clean. There was no any signs of infection there. And we just continue to dress this baby using hydrogen peroxide for cleaning the wound and the normal saline for cleaning the wound. But when we were dressing, we were using honey. We started using honey so that the wound can granulate. We also used mupirocin cream as an topical antibiotic, plus the Vaseline gauzes. So we managed to control the infection, and the wound was clean. And we took this patient out of ICU, and we took the baby to the wards. But again, surprisingly, we don't know what was happening to this kid. It was a complicated case. The CSF leak started again. It was reduced, but it was there a little bit. And the patient started to present with the signs of meningitis. I mean, meningismus, having a stiff neck, and the Koenig and the Budinsky sign were positive. So the HB at this time was 9 because he was getting he was still getting the blood transfusion. And we stopped the cefoso, and because this is meningitis, we started to use the strong antibiotics. We started using the meropenem and then vancomycin. Meropenem is very good in gram-positive bacteria, and the vancomycin is very good in gram-negative. So we combine this together with the IV fragile metronidazole for the anaerobes. We try to do the lumbar puncture so that we can take the CSF for culture and sensitivity. But we could not, because the lumbar puncture was negative. Wherever we tried, I tried myself 2 times to get the CSF. It was not coming. We called for the assistant from the anesthesiologist who came later and did lumbar puncture. But again, we could not get the CSF. So we stopped it because we were thinking that this was traumatic. We cannot do anymore. So we stopped doing the CSF, but we kept the baby on the IV meropenem, IV vancomycin, and IV ceftriaxone. This is the status of the wound. This was before when the patient presented to us, and this was uh, the situation of the wound later after the third operation using the Duragen. Now you can see the function of the honey. The wound has granulated. The wound is clean. This is the Vaseline gauze. We are putting the Vaseline gauze. And we could not manage to get the lumbar drainage because even the CSF lumbar puncture was not possible. So even the lumbar drainage catheterization was not possible for control of the CSF leak. But later, like 2 days later, this patient stopped leaking CSF because of the granulation of the wound. We thought probably because of the granulation, that part which was gaping, it was covered. So the wound stopped. So we are just dealing with the dealing just with the wound management. We are just continuing with the wound management. But the situation again changed. This is the picture showing that we are using hydrogen peroxide. The situation changed to the baby was getting like heady nodding. It was now becoming, initially was talkative, but now it was mute. He could not speak most of the time. And the fever, we tried to control the fever because he had on and off fever. We were using IV paracetamol, and sometimes we were exposing the baby and trying to use the wet towel to just use it on over the body of the boy. And we consulted the pediatrician, the pediatric neurologist, to come and view this baby for the management of the fever, as we were just using suppository and IV paracetamol without any success. We did also serum electrolyte, and we found that the electrolyte, this baby had electrolyte imbalance. He was having severe hyponatremia, hypokalemia, and we started correcting the hypokalemia and hyponatremia using the same guidance, the same protocols. So these were the most difficult or the challenging the challenges we got on management of this baby was the infection, in this case meningitis, the CSF leak, which of course later stopped, but probably because of the granulation of the wound, we did not use the lumbar catheter. The other thing was the challenge was covering the bone. Now we cannot use methylcrylate bone cement because this is what we are using here, because this is the kid is growing. He needs to grow. The skull bone is growing. So if you use bone cement, it won't work. And at that time, the infection was not well controlled. So we could not put the foreign body over the infectious part. So we are waiting. But the alternative was to use the os patch, which we actually don't have here in Tanzania. I found this when I went to Turkey in the WFNS meeting, World Federation of Neurosurgical Society in Istanbul, Turkey. I found this company Surgery they were selling a product called the os patch. They say this can be used in kids because it can heal with the bone and it grow. And we asked them about the effectiveness of this product. We say, of course, it's a new product. It's less than 6 months since they launched it, so they were not sure. So we are still we have not used it, but we are ordering it. So probably we are going to use it and see if it's going to help the baby. Another challenge was the skin flap. The plastic surgeons here, they were stuck on what they are going to do. They were thinking of doing a muscle flap, but harvesting the muscle from the thigh or from the back. But I cannot comment much on this. This was left for the plastic surgeons who did not conclude on this matter. So we were left on just treating the infection and treating the electrolyte and the condition were improving. Well, this is what I wanted to share with you, especially. But the other thing I want to ask to share with you is the control of the rabies and tetanus. This kid had symptoms of neck stiffness, fever, and sometimes he was getting like head nodding. We could not really evaluate if this was rabies. We just thought this is just meningitis. It's not rabies. We tried to rule out meningitis and we tried to rule out tetanus. Of course, tetanus is ruled out because the patient had no trismus, the lockjaw. He had no lockjaw, so we thought this is not tetanus, and we were just left with the rabies option. But we also think this is not rabies. So in your mind, when you are treating animal bites, you should also always consider rabies as the risk factor. Thanks. Thank you for listening.
Great presentation, Dr. Juma.
Yeah.
You clarified most of the things. I have a few questions.
Sure.
Very good. Okay, you can get off the Hangout, get off the screen share, Juno, by clicking on the green arrow again.
Okay. Screen share.
If you want to. Yeah, you finished the presentation?
Yes.
Okay, just click on the. There you go. Thank you very much for an excellent presentation, and thank you. I'm sorry the lights are out here in Nepal, but the the dedication that you guys took to pursue aggressively that case and to treat all the problems, etc. And I'm sure the other panelists feel the same. Okay, the panelists, would you like to comment or ask Juno some questions?
Yeah, Dr. Juma, I have a question.
Okay.
Yeah, you mentioned that the child had brain herniation, right?
Yes.
So what happened of it? Were there any complications, or was it reversed? What happened? Can you tell us?
Okay. It was from the bite of the animal. So the animal, the hyena, took the scalp. He took the bone. He took the pericranium even, and the part of the dura was teared, exposing the brain. So the brain, the term herniate, the brain was coming out from the defect, from the dura defect. So it was like strangulated. On arrival, that part of the brain which came out was already dead. So we just took it out. But surprisingly, this baby had no any neurological deficit.
Wow.
It was moving the limbs, it was moving the arms, the upper limbs, they were okay.
Okay, can you tell us that the hyenas usually would, when they would hunt, they would attack the neck, right? The hyenas attack the hyena, animals hunt on the neck, right?
Yes.
So why did they start hunting the child from the head?
We actually don't know, because the way they were sleeping in that house, according to what they say, it looks like the hyena was searching for was smelling something.
Yeah.
So when he found that the smell was coming from the boy, he just captured what he had. He captured the skull.
Okay.
So when the baby cried severely, then the uncles wake up.
Great.
Did you finish, Joseph?
Yeah, I finished.
Okay. I wanted to say that really I'm long time with Neurosurgical TV, and this is really one of my favorite presentations so far. I must say that I was really amazed, because as you went through, I had many questions arising. I even thought it would be great to hear what kind of microbes are hidden in the bite of hyena and everything. And as you went on, you answered all of my questions. The Valsalva maneuver, how the wound healed. I really think that you presented a wonderful medical knowledge and dedication, as Dr. Bennett said, and it's really I must say that it was really not just a pleasure, but an honor to listen to you. So I'm really amazed by the presentation. It was not just a case presentation; it was an overview of decision-making process. And I basically have no questions. You answered everything, but I just wanted to state that it's really remarkable. The case you presented, and I'm really looking forward to hear more of your presentations. Thank you so much.
Yes, Juma, we look forward to hearing a lot more presentations from you. One comment I want to make, I imagine the defect itself can cause a lot of problems with further infection, correct?
Sure, yes.
The defect of the skull invites infection. Now, you know, this is probably kind of far out. There's a technology now called 3D printing that makes you know, by 3D printing and tries to cure the defect with 3D printed cranium. Have you heard any of that? About any of that technology?
I heard about that technology, but unfortunately we don't have it here. And I'm just thinking of using it because the child is growing.
Right.
So we are thinking the metopic suture is growing. We are afraid of using even the 3D printed titanium cage, because probably if we use it, we will restrict the growth of the baby, the skull of the baby. So we were thinking of using that product, the os patch.
Okay.
We are still ordering it. We have not received it.
Oh, but you did discuss it.
Is it?
Oh, okay. Very good. Very good.
Yeah. Yeah.
At what age would you consider a 3D printed titanium implant? What age does a child's cranium stop growing?
I think over 14 years old. 14 years old.
14 years old. Okay.
Yeah, 14 years old, I will consider using the titanium cage.
Okay. Very good.
Yeah. Yeah.
Very good. Simon, do you have any questions or comments?
Yes, Doctor, I apologize for arriving late, but I'm the editor of the videos, and I'll be sure to watch the video in detail tomorrow, and I will look forward to seeing the video. Thank you very much.
Yeah. Well, you know, the neurosurgeons are the ones that have to take care of problems like this, obviously. And there are all different types of trauma in our society as compared to your country. But it's certainly interesting for me to hear about something like this. I'm sure there are animal bites that happen in this country. Is it a pretty common occurrence?
Yes.
I guess do you see a lot of animal bites there in Tanzania?
Yes, we get a lot of cases. Only this because this is the only center we are doing neurosurgical. But there are a lot of animal bites. People live close to the national parks, and they get animal bites probably because from the other parts of the body, from the arms, from the legs, so that they don't present to us. But this is the second case for me. One was from the buffalo horn. He hit the man, and another one is this one. So we are probably going to get a lot of these cases because we have a lot of national parks and people are living there. So the risk is high for these farmers and other people.
Yeah, a lot of national parks there, huh?
Yeah,
Tanzania?
sure. Yes, a lot.
Yeah, that was nice. You mentioned he took us on a little tour of Tanzania. That was kind of nice.
Yeah, sure.
So
it'll be my pleasure to welcome you.
Well, you know, Dr. Cherian goes to a lot of conferences in Africa, and hopefully we'll someday we'll be able to go to. I have corresponded with a nurse in Zambia, and it was very interesting fellow. And we hope to get the neurosurgeons of Africa together on this platform and bring neurosurgeons to you also from other parts of the world, such as Dr. Cherian here in Nepal, where he hopes to be filming live neurosurgery. So hopefully we can involve you and your associates in these type of programs in the future. And I'm sure Simon and Slaven and Joseph will also be part of it. But a great presentation, man. That was great. That was definitely one of my favorite too, I think.
Yeah,
And we hope to see you a lot more, Juma, and we welcome you and any of your community to give presentations whenever you feel like it.
Thank you so much.